welcome to part 2 of our Guilt and Shame Common Client Conundrums segment. I'm your host, Juniper Owens, Director of the Academy of Integrative Mental Health. And in part 1, we discussed the anatomy of guilt, perceived and disproportionate guilt, and ways to work with chronic or distressing guilt. We highly recommend listening to part 1 first, as guilt and shame are similar in many ways and often occur together. So even though we've all experienced it and we all feel it to certain degrees, and it's not necessarily the most fun or exciting thing to feel. What exactly is shame? What the heck is it? Shame is a complex and powerful emotion that involves a feeling of embarrassment, humiliation, or distress about one's actions, behaviors, or circumstances. It typically arises when an individual believes that they have done something wrong, violated societal norms, or fallen short of their own or others' expectations. Shame can be both a self-directed emotion where a person feels ashamed of themselves, or it can be imposed by others through judgment or criticism. So first, let's zoom out a bit and explore the macro system of cultures and how they influence the individual experience of shame. Shame is largely a social construct that is influenced by cultural and societal norms and expectations. What is considered shameful in one society may not be seen as such in another. For example, in some cultures, nudity may be viewed as shameful, while in others, it may be seen as natural and even celebrated. Universally present across all cultures, shame serves as a tool for social control, fostering adherence to norms. However, its personal effects, including isolation, loss of agency, depression, and even suicidality, are detrimental, with limited evidence that imposed shame leads to positive behavioral changes. Cultural senses of collective shame refer to the shared feelings of guilt, humiliation, or embarrassment experienced by a group of people due to historical events, actions, or circumstances associated with their culture or race. This collective shame can arise for various reasons, including historical injustices, atrocities, or negative stereotypes that have been perpetuated over time. It can manifest in various ways and affect individuals within the culture or race, even if they were not directly involved in the events that led to the collective shame. Here are a few key points to consider regarding cultural senses of collective shame when offering different ways to approach shame in a therapeutic context for your clients. First is historical trauma. Collective shame often stems from historical trauma such as colonialism, slavery, genocide, or war crimes. These events can have long-lasting impact on a group's identity and self-esteem. Intergenerational. The sense of shame can be passed down from one generation to another through storytelling, cultural practices, and the collective memory of a group. Descendants may inherit feelings of guilt or responsibility for actions of their ancestors. We also have stereotypes and discrimination. Negative stereotypes and discriminatory practices against a particular culture or race can perpetuate collective shame. These stereotypes may be based on historical events or misconceptions, leading to feelings of inferiority or stigmatization.
Ever since I learned that there was something called an angry Black woman, a mad, angry, vengeful, hateful Black woman. Basically, ever since I learned that the prevailing stereotype in the American imagination is of some angry Black woman who's out of control or who's a whore or the B word or the N word, she says, I've tried not to be that. And I didn't even realize that with all my education and my multiple relationships in various communities, I had been doing the same thing. We spend so much time trying not to be this thing that we don't get a chance to fully express the full range of our humanity. Because at its core, racism robs you of your humanity. Because if you're truly fully human, you get to experience the full range of your emotions. Sometimes you're happy, sometimes you're sad, sometimes you get to be angry, especially when you've got cause.
Women, and in particular Black women, are less likely to receive adequate healthcare treatment, including pain medication like before, during, and after surgery in comparison with white males. In addition, Black women face significant health risks based on this discrimination. For example, being born in a Jim Crow state heightened Black women's risk of being diagnosed with estrogen receptor negative breast tumors, which are more aggressive and less responsive to traditional chemotherapy. So this is where J. Marion Sims comes in, who is often credited as the father of modern gynecology. He made contributions to the field of women's reproductive health by developing pioneering tools and surgical techniques in the 19th century. He achieved prominent positions in the medical community, serving as the president of the American Medical Association and president of the American Gynecological Society, which he helped found in 1880. But Sims' legacy on women's health is deeply troubling.
Of reproductive health in the United States has really been defined by significant state violence against poor women and especially women of color. He experimented on slaves to perfect tools used in gynecology and procedures, and housed his slaves in the back of his house. What he called his medical suite was a shack, basically in the back of his home. He'd wake up in the middle of the night when he would, as he described it, have an epiphany in the middle of the night. He'd need to go in and grab one of the slaves and put her on the operating table. He would rouse Lucy or Anarcha or another without any anesthesia or the aid of any kind of pain relief. He would begin lacerating, cutting into their uterus, experimenting with C-sections on women who were not pregnant, cutting across their wombs over and over again to perfect what he was imagining in his sleep, essentially.
This history of using enslaved Black bodies as medical test subjects is part of a broader, ethically questionable pattern in the field of medicine, which includes infamous instances like the Tuskegee syphilis experiment and the case of Henrietta Lacks. Sims prioritized his experiments over providing therapeutic treatment and inflicted immense suffering, all while operating under the racist belief that Black individuals did not experience pain. Consequently, pain invalidation is associated with poor mental health, including depression and lower well-being in general. Qualitative investigations of invalidating experiences identify themes of depression, but also social withdrawal, self-criticism, and lower self-worth, all of which are core components of shame. So you can see here an example of how shame can be related to the ever-persistent legacy of historical events, which occur today. This implicit bias still stands true based on the research that women, in particular Black women, receive inadequate mental health treatment and inadequate pain treatment. So it's a really good example, I think, of how this can show up and how this can be a source of shame.
And I did not realize that I had gotten so good at packaging my own pain. I had gotten so good at holding on to my own anger and frustration that I didn't even realize when I was doing it on a day-by-day basis.
So now that we've looked at the systems involved in shame and distinguished between shame and guilt, as we've been doing these first two the first two parts, we continue the assessment phase by exploring the profound work of how shame takes root in one's sense of self and how one fits into the world. So again, let's look at some of the symptoms or effects or what you might notice associated with guilt. First, we'll start with emotional. We have intense feelings of embarrassment or humiliation, low self-esteem and self-worth, overwhelming self-criticism, persistent sadness or depression, anxiety, feelings of isolation and alienation, anger or irritability, often directed inward. Cognitively, we have a lot of negative self-talk and self-blame, intrusive and distressing thoughts about past actions or perceived flaws, self-focused attention often on perceived inadequacies, and tons of cognitive distortions like all or nothing thinking, catastrophizing. Is there any other therapist that can never say that word and it's always embarrassing? I have some work to do around that, as you'll see. Okay. Behaviorally, avoidance of situations, people, or triggers that evoke shame, withdrawing from social interactions and lots of isolation, self-destructive behaviors, including self-harm and substance misuse, perfectionism as a way to compensate for feelings of inadequacy, people-pleasing or seeking excessive validation from others. There's physical symptoms as well, like discomfort, like blushing, sweating, or trembling when you're experiencing shame, fatigue and low energy due to the emotional toll of shame, also sleep disturbances. Interpersonally, it can affect our relationships by really creating a lot of fear of judgment or rejection from others, can prevent forming and maintaining healthy relationships. Sometimes the avoidance of eye contact and body language conveys shame. Also, difficulty in expressing one's thoughts and feelings openly. So there's a lot of communication stuff that shame can really muddy the water there. And there's also shame resilience mechanisms. Some individuals may develop defense mechanisms or coping strategies to protect themselves from shame, like denial, disassociation, or projection, among others. So that's something also to look out for with shame. So research has shown that we frequently deal with shame in 3 ways. 1, we distance ourselves from others by hiding our true selves, withdrawing from our relationships, and keeping secrets. 2, we try to please those around us to earn back our worthiness. And 3, we express our shame through aggression or by shaming others. So I don't know about you all, but all 3 of those seem to be some pretty core issues that come up for a lot of us and our clients. As we discussed earlier, shame is not as much about what you did, but about who you are as a person. Shame can be and is often tied to trauma and PTSD. That's why working with shame in these contexts should be treated with the utmost care. Shame tends to be more primal or physical and typically does not involve cognitive processes such as logical thinking or reasoning. You see, it operates as an automatic stress response that essentially takes control of the brain.
Just talking about shame in terms of physiology is already de-shaming because, we're talking about it as a mammalian response, right? Rather than somehow our fault or our moral failing. But somehow seeing our typical responses to threat, for example, which is either, to come at it with aggression or to come at it with a freeze, deer in the headlights response. And seeing that as a defense, the organism is just taking care of itself, is a way to kind of be nice to ourselves about it. Like, oh, well, okay, so this organism that I call me was just trying to take care of itself when feeling threatened. So it shut down or it acted out of rage. And it's, this is part of building a general sense of common humanity, or I take it further, common mammalian nature that we all participate in, which when we feel part of the larger collective, that is such a powerful antidote.
Research demonstrates that when the brain's limbic stress response is heightened, the prefrontal cortex responsible for logical thinking becomes less functional. Also, studies have established a connection between shame and the innate instinct for self-preservation. Experiencing shame activates the same neural circuits that compel individuals to seek protection, similar to the response to physical threats. And that's the great paradox here of shame. You feel like a horrible person and you want to feel better, but the self-reflection required to improve your life probably feels threatening. So you stay in fight or flight mode as a way to protect yourself, and the cycle continues. But there are evidence-based approaches to working with reducing the effects of shame. So first, we really want to just address the self-criticism that goes along with shame. Self-critical and self-attacking thoughts are often integral to the experience of shame. These thoughts are considered crucial targets for intervention because they trigger, perpetuate, and intensify emotional reactions. Rector and colleagues in 2000 have suggested that individuals who are highly prone to shame and self-criticism, especially those dealing with depression, may not benefit as much from standard cognitive behavior therapy, or CBT, compared to their less self-critical counterparts. They emphasize that the extent to which self-critical thinking can be modified plays a crucial role in treatment outcomes. Furthermore, shame has been found to significantly disrupt key attributes of compassion, particularly empathy. Some treatment studies have shown that elevated levels of self-criticism before therapy predict less favorable treatment outcomes. So, given the above findings, it may be beneficial in therapy to assist individuals experiencing high levels of shame and self-criticism in cultivating self-compassion and redirecting their focus towards self-warmth rather than self-critique. So let's talk about some ways to do that besides psychoeducation on systems and macro elements of shame that we discussed earlier. So let's talk about embracing shame, like just embracing it, like, yo, what's up? Shame. Shame, come on, come hang out with me today. So I do my own particular work by humor and always having these like hilarious avatars in my head that are having all these conversations. And the one that embraces shame is like, yo, what's up, Shame? You made it. We are so glad you're here at this party of all of our parts, and you are welcome here, even though you can be a little ass sometimes. Like, come on, you're a part of us. That was embarrassing to share that. But anyhow, to effectively address shame in therapy, it's crucial to guide clients in confronting and understanding their own feelings of shame, even though this process can be emotionally excruciating. For individuals who are prone to shame, avoiding it can become a central part of their lives, leading to behaviors and coping mechanisms centered around shame and its avoidance. However, this avoidance obviously can hinder their personal growth and learning opportunities. Research has indicated that exposing clients to their shame while incorporating perspective-taking and compassion exercises can help them develop healthier responses to the shame that just go beyond avoidance. Like I said, the goal is for shame to be around and it's not so distressing, because it will occur because it's a natural occurring human emotion. One therapeutic approach that some therapists use is called psychodrama, which involves acting out significant events or emotions. And this can help by inviting in the shame, for example, and really feeling it and addressing it in session. So like we're facing it like right there. So for example, I once worked with a therapist on establishing boundaries in my relationships, which were a source of shame and guilt for me. And in this session, she had me stand in the middle of a room, and we drew a line on the floor to symbolize a personal boundary. She then physically crossed that line and gently pushed me backward toward the wall, symbolizing what was happening in some of my interpersonal relationships at the time. So in this scenario, I reacted in my typical manner, which is to laugh nervously and struggle to communicate that she was crossing a boundary, which we had previously set, because for some reason, the way that I respond to those things are like just to be like, it's okay, it's fine, I'm okay, even though you're like totally across my line and pushing me up against a wall, like it's fine. This therapeutic technique allowed me to physically and emotionally experience the boundary violation, offering a powerful way to confront and process my feelings about boundaries and the shame I experience when I allow a boundary to be violated, or when a boundary is violated without my permission. And that's obviously rooted in my personal trauma history. It's created a safe space for exploring and understanding my reactions, and it provided an opportunity to develop healthier responses in my real life relationships. Such exercises combined with therapeutic guidance and support can be instrumental in helping clients address shame-related issues. Also, assessing warmth and belonging is really important here. When working with shame-prone clients, it's crucial to assess not only past experiences of criticism and disconnection, but also experiences of warmth and belonging. By eliciting and identifying these positive experiences, or these experiences in which we're regulated, therapists can help clients build self-compassion. If the client cannot access such memories, which is often, or sensations, those can actually be created in session. This includes like resourcing, therapeutic alliance, and corrective emotional experiences, and should not be glossed over. So it is very powerful for clients to have warmth and belonging experience in session. And I always say, like, slow it down a bit and point it out. What are you noticing here? Because it's sometimes hard to know when you've been in hypervigilance mode and all of that great stuff that you are experiencing warmth or something like belonging. And so we really like to point that out in session. Also, pay attention to how you express warmth and positive regard, especially with highly critical clients. Research has shown that therapists tend to show less warmth when clients exhibit high self-critical perfectionism. It's important to be mindful of your clients' responses to warmth and adjust your approach accordingly, as intense expressions of compassion may feel overwhelming to highly critical clients. Be attentive to nonverbal signs of shame, which can be more reliable indicators than self-reports. Nonverbal signs of shame include downcast eyes, blushing, slumped posture, covering face or mouth, nervous behaviors like finger tapping or wreathing your hands together, decreased vocal volume, prolonged silence or long pauses, and self-touching like touching hair, face, or neck. As we previously discussed, shame is experienced somatically and most of the time without our awareness, as it's an autonomic response. So including somatic techniques like grounding, self-soothing, like butterfly tapping or havening, or just even physical gestures that are calming and regulating, like drinking cold water or hot tea. This can help the body to feel safer and allow the mind to do some of the cognitive work that it takes for self-compassion or to really get into the cognitive aspects of shame. Also, loving kindness meditations can be helpful for some clients, and there's a decent body of scholarly evidence to support that. My favorite loving kindness meditation is one in which I guide my clients in a visualization. So like first they visualize themselves in their mind's eye. And I have a little trick for that because sometimes that can be really difficult to visualize yourself for some people. So before we do this, usually in sessions, like I always have clients kind of like do like an avatar of themselves, like how do they see themselves? From some clients, we might need to externalize this a little more. So the avatar might be a bird, or it might be a type of a plant that they associate themselves with, something like that. And so if a person can't visualize themselves, maybe they can visualize this like avatar of themselves that they can use to work with these aspects in session. And I like to keep with the same avatar unless it changes for clients. So anyways, they are imagining that self, and you just imagine all of that self's pain and suffering and sorrows and all of their life experiences and all of their qualities. And you basically breathe in all of that suffering and you breathe out like clear, healing light upon that person or whatever it is. Is it sparkles? You can breathe out sprinkles. You can give them an ice cream cone or a peanut butter and jelly sandwich, whatever it is that you want to do to like soothe and regulate and comfort that person and like, you know, care for them or offer them compassion. And so you breathe in their suffering and then you breathe out compassion, whatever that looks like for you. And again, when you're breathing in the suffering, you're not like taking it on as your own fault. It's almost like you're transmuting it. So for some people, breathing in doesn't work. So you just say, I'm imagining, you know, smacking your suffering in the face. No, sorry. Again, I'm very humorous and this helps me. Whatever it is that works. Then and some people like to do mantras like, I wish this person happiness and health or whatever it is. Then the second one is that you do someone that you love. So you picture someone that you love and you care about in your mind's eye, and then you do the same thing. And then the trickier one, and you don't even have to do this one, but if you want to add it in, is to imagine someone that you don't particularly love, or someone that you have judgment on or that you don't like. I know a lot of people use certain political leaders or something like that in their mind's eye. And then you do the same thing. You imagine them as a human with all their suffering and experience. And then you imagine their suffering being sprinkled with compassion. So that is one technique that you can use. That's like kind of a mixture between the Tibetan form of love and kindness meditation and like my own weird stuff that I add into it. So you can make it your own, or you can do a formal loving kindness meditation. Choose your own adventure. Sometimes clinical self-disclosure could be indicated. This is just the acknowledgement that the therapist is too human and also may experience shame and embarrassment even in their work. This is a normal part of being human, and therapists should practice self-compassion and self-care while modeling these qualities for clients. So I'll share another example. I love throwing myself under the bus. So, for example, I once made a mistake with a client I was working with and felt great shame, self-criticism, and disgust with myself like many days afterwards. It was, in my mind, a pretty big mistake because I felt that could have been harmful to the client. It was like a mistake in the words that I chose to use. And I just thought to myself, like, how could I do that with such a vulnerable client? And I fucked up. Like, I was so upset with myself. If I haven't made it clear already, I deal with a lot of shame and guilt. And for me, one of my biggest triggers of all is making mistakes. So yeah, it was a big one. So anyways, after discussing it with colleagues, I decided to address it with the client. And by naming my mistake and sharing my guilt and shame associated with it, it made space in the session for a shared experience. And I was able to model how to address it. And also I named how much better I felt once I shared and apologized. I told my client that I used writing and talking to colleagues and art to address the lingering discomfort of the shame until it felt more manageable. So it ended up being a very good clinical judgment to disclose that because it was incredibly helpful for the client, and they felt seen and witnessed because the comment that I made did cause harm to them. And they were able to feel validated and supported that I was able to name that. Say, oh, when I said that, I wasn't thinking about your past experience with such and such, right? Okay, moving on, because now I'm embarrassed. So I'm going to have to go and do some self-compassion work after this. Oh, it's also really important to understand the strong connection between shame and trauma. Individuals with trauma histories often experience high levels of shame, which can significantly impact their well-being.
Now that we know the definitions of both shame and trauma, let's get into why they are so connected to one another. I personally believe that shame is only linked to certain trauma experiences. Hear me out for a minute, because I believe that shame is only associated with traumas that we feel we are responsible or could have stopped. This is obviously dependent on our own personal experience during or after that traumatic event, but if we feel that we could have or should have done something to stop it, we can feel full of shame as a result. Because think back to the definition of shame and how it can cause us to feel that we are just wrong or bad. And if we felt that we could have done something to stop the trauma from occurring or did something to cause it, of course we would struggle with feelings of shame.
Assess and address shame when working with trauma survivors, always. And we do this a little later in the trauma work, right? This is a little more advanced. This isn't session 1 trauma work, is to address the shame. A little bit later on, but just make sure it's addressed. And we can't finish a clinical discussion on shame without mentioning Brene Brown. Brene's the developer of shame resilience therapy. Based on her research on shame in her groundbreaking book, Gifts of Imperfection, she believes shame prevents worthiness from developing because it's completely contrary to everything worthiness represents. It's built on foundations of fear, self-hatred, and the sense that you're not enough. Worthiness simply can't flourish if you think this way. Brown urges people to, quote, speak your shame. In giving her second TED Talk, Brown was able to deconstruct her shame in a very public forum, further letting go of her own shame and helping the audience better understand their shame. So, shame resilience theory, to my understanding, has 4 main aspects. 1, to understand your personal vulnerabilities related to your shame. 2, gain critical awareness of the social and cultural expectations that affect your feelings of shame. 3, form mutually empathetic relationships and reach out to others. 4, learn to speak about your shame and therefore deconstruct it. For some clients, the therapeutic value of being fully witnessed in their entirety is significant because many people tend to conceal aspects of themselves that they deem shameful. When they can openly express these concealed parts and receive acceptance in a safe environment, the overwhelming power of shame can diminish, making the experience more manageable. The objective is to reach a point where shame can be observed from a detached perspective, like akin to adopting the wise mind approach, like we talked about it. And my avatar for the wise mind, aka, is a carefree attitude reminiscent of a grumpy old lady who wears caps, smokes cigarettes, and enjoys a daily laugh at her own expense. I just had to share that. So anyway, the objective is to reach this point where shame can be observed and detached. This shift loosens its hold and creates room for broader perspectives, increased understanding, and most importantly, reduced self-criticism and emotional regulation difficulties associated with shame. Shame can be a tricky beast to tackle, but understanding its nuances and how it affects our clients is a significant step towards helping them navigate this complex emotion. We've learned that shame can wear many masks, from cultural and societal pressures to the intensely personal experiences of our clients. And remember, therapist, it's not just about identifying shame, but also helping our clients develop the tools to face it, to embrace it, to name it, and to tame it. Oh, all right. Thank you so much for joining us, and please take care of yourself. These conversations and these discussions obviously can be tiring or bring up some stuff. So do something good for yourself, possibly. Maybe something regulating or something compassionate or supportive. I personally am going to go take my dog for a walk because she hasn't walked since the morning and she probably needs to. And then I'm going to give myself maybe something sweet to eat, like a little sweet treat. And should I take a break? What time is it? Maybe I'll take a break. Maybe I will take a break from work for the day. Maybe not. We will see. All right. What are you going to do to take care of yourself and also possibly others, to support others? Okay. Like, subscribe, share, comment, do all the things, pretty please. We really appreciate all of your support, and we are really here to provide resources that are useful and modern and supportive to you in your work and in your journey every day. So the best way we can do that is by getting feedback on what you want to hear, what you're interested in, and what will be helpful and supportive to you. So we will link all the things so you can reach out, and please do so. But also like and subscribe, because then that helps other people. That helps other people to get this information if it's helpful to them. And I know you hear that a lot, but like, it's true. It's super true. Like, I will spend an entire 3 months on a podcast episode and get 5 views, and it's make me feel sad. Oh my God, I have so many bloopers for this. Okay, peace out. Thank you all. Take care.